All right, guys. Welcome to Journal Club. It's fantastic that Journal Club's starting to get a bit more traction and people are getting into it. And what's really cool is we're getting views afterwards. After the recordings go up, people are starting to get interested. And it's great to knowledge share and sort of expand our practice. So I'm going to start with Post Operative AF and colchicine, POAF. and it's more of an interesting sort of stimulus for talk, because I came across this article and thought to myself, I don't do this. And the question at the end of this should be, should Dr. Pillay start doing this, yes or no? Because we should have a group discussion. And what does Dr. Fulton think? What does Dr. Chen think? What do all of us think? So it's a very interesting article. But before I do that, I just want to show you our obligatory marketing video. Sam, I see you. I see you driving. Yeah. Sam, back from gym.
Yes. Sam, look at the road, man. Yes.
Just listen, Sam, don't look.
All right. Can I get my slide back? Tish?
It's on the one, Tish.
Oh, okay. All right. Okay, I'm sure you guys, I hope you guys can see my slide. All right. So a meta-analysis of colchicine in prevention of atrial fibrillation following surgery or intervention. It's a whole lot of words, but atrial fibrillation post-op is something that affects a lot of our patients, right? And then it affects the outcomes, the mobilization, all of this. And we have our sort of approach that we normally use. In JJ&J, it's routine for us to give everybody a maintenance dose of amiodarone following cardiac surgery. And just for the guys who are going to watch this when it's recorded, and especially some of our nursing staff, a meta-analysis is a type of study or review of studies. So it's not a single study. They look at multiple studies and they come up with a combined sort of consensus, taking out biases, looking at the thing, and it's quite interesting because it's quite a powerful thing, because you use the evidence of multiple researchers. So meta-analyses are quite powerful things if done properly with the right tools. So this article was in this month, or it was in December last year, of the Journal of Cardiothoracic Surgery. So let's quickly go through a quick introduction. So the incidence of post-op AF has been reported to range between 10 and 50%, and patients undergoing valve surgery are at the highest risk. So post-op AF is associated with bad clinical outcomes, prolonged hospital stay, expanded cost, and increased morbidity, mortality. So this doesn't just concern the surgeon. It's not about which stitch is better or which thing. It's about the outcome of the patient, and it includes everyone. Pre-op, intra-op, post-op. So it includes ICU, the ward, everything. How do we optimize this? Now, when we do surgery, we create a massive inflammatory response. It's a local as well as a systemic inflammatory response. And this may play an essential role in the pathogenesis of atrial fibrillation. And there's been increasing interest in the potential use of anti-inflammatories, right? So, and using these as therapeutic drugs. So anti-inflammatories, we know things like Disprin and all the non-steroidals and that, but colchicine's been used widely in the treatment of gout previously. And then people started thinking, well, if AF is caused by inflammation, would it potentially help? Right, so what the guys did in this meta-analysis is they identified a whole lot of studies, all right? So they went through PubMed, they went through all the high-rated journals, they went through the Cochrane database, and they identified 149 studies, right? And then they started screening them, and they excluded quite a few. So things that weren't randomized control trials, things were just review articles, things that were missing research, or things that they couldn't correct for bias, they removed all of that. So out of 149 studies, they ended up with 9, but 9 good studies. All right, so interesting. So it's quite a busy slide, but we have 9 studies, and you see that these guys all gave colchicine, but at different doses, different intervals, and different durations. Also for different things, because it's interesting. So Besiso et al. Gave it just primarily for lung resection surgery. Defterios gave it for pulmonary vein isolation. So he's also trying to treat arrhythmic or arrhythmias and that in that sort of group. And the main terminal point was for post-op AF, or in the vein isolation group's recurrence of AF. And the rest of the studies were what we do, mostly bypass surgery, aortic surgery, valve surgery combined, and revascularization. So it's quite interesting that these guys, some gave it for 30 days. Everybody got it for 30 days. Some people gave it for 3 months, some people for 1 month, some people for in hospital. So if we had to look at all the results of these studies, right? Now this is a really cool thing. Once again, for the guys who are watching this recorded, or even the guys on the call now, this is something called a forest plot, right? And if you look at a forest plot, there's a sort of T, and on one side you've got your control group, and the other side you've got your intervention, or the thing you're investigating, and it weights your study with all the evidence and all of that, and it puts it on a forest plot, and to talk about all those risk ratios with the confidence intervals. But what you really got to look at is, where are those dots for each study? And the further they are to the side that favors, the more heavily their outcome is positive for that side. And that diamond at the bottom is sort of says, okay, if you combine all of this, this is now what the study says. And this is interesting, that they show that for the risk for post-op AF in this group of people that were using colchicine is high. So you're not giving the colchicine to people who are not going to get AF, right? So these people do get AF. And then this is just more data that shows that different durations of colchicine use sort of is related to the risk of AF, but not very, very much strongly. So I just want to talk a bit more about this, and you guys can look at this a bit more in detail, but there's no point going through every single figure in this forest plot. So what was the main outcome of all of these studies put together? Well, they say colchicine significantly reduced the risk of incidence of AF with a p-value less than 0.05, which is significant. So as researchers, we want to look at p-values, just as something to say, should I listen to this or shouldn't this? So they're saying, yes, it's significant. And then the subgroup analysis, so they looked at the subgroups and they said there's significantly lower risk of post-op AF in people taking it in both long-term groups and short-term groups. And they can't really tell how long should you take it for. Should you take it till discharge or so there is benefit, but how long should you take it? But also the risk of adverse drug reaction was significantly increased. This is also the p-value of 0.05, but the adverse reactions were listed as gastrointestinal things, primarily diarrhea and bowel upset. Certainly not adverse in terms of life-threatening things. So as a clinician and as a multidisciplinary team, we got to say, is it worth the risk of getting diarrhea? And interestingly, I think it's somewhere in one of the other slides, the longer they were on the colchicine, the less the adverse reaction was. So it's almost like you take it, you get diarrhea, and then you get used to it, almost. So we can, just at the back of our mind. All right, so like I said, 9 randomized controlled trials, so high-powered sort of research across the world. 2,031 patients undergoing surgery or intervention. So there's quite a big sample size. And the results showed that colchicine could significantly reduce it with an estimated decrease of 38%. So that's quite a lot. All right. And the subgroup analysis demonstrated the risk of AF was in both surgery and intervention. So it wasn't just open surgery, so any cardiac intervention in that, but both of them had markedly decreased risk, okay? And also interestingly, although we know that valvular surgery has more AF, but they say the approach to surgery and the type of surgery has very little effect on the incidence of AF. So, so the duration, as I said, not statistically significant. So my question, obviously, in my head is: should I give them a once dose, or should I give them or should I give it at all? So we can chat about that now. Adverse reactions were a lot more. So this is the diarrhea, gastrointestinal things, and then we got to decide, is this worth the risk? And it didn't increase with the duration, and the long-term group actually had a lower incidence of adverse reactions. So the mechanism of post-op AF is not fully elucidated, and more evidence is suggesting that inflammation plays a role, and especially things like posterior pericardial collections. I know as a group we've started doing posterior drains that drain widely into the pleural space. We're reducing the amount of posterior thing or part of this. And because of the inflammation and the fact that measurably colchicine decreased post-operative CRP and IL-6 levels, we think this is the mechanism, or when I say we, I say they think, and I also think that's the mechanism that is reducing the AF by decreasing the inflammation. So what do we do currently, right? We control rate in the patient, we control rhythm, and that's how we treat our AF. Like I said, in our practice, we give amiodarone, 900 milligrams in 500 over 24 hours. It's a standard thing, all post-ops get it, right? So you can use amiodarone, beta blockers, calcium channel blockers, and these are commonly used to prevent AF. But the long-term effectiveness of this is limited. And I think we can discuss that. I've had one patient who's had lung fibrosis because of quadrone. Well, we think it's because of the quadrone and we are trying to control post-op AF. And then there's also non-pharmacological treatment when medical treatment fails, radiofrequency ablation, and then also in the acute setting, our conversions, pharmaceutical and electrical conversions. So that's currently how we sort of treat it. So in conclusion, the mechanism associated with atrial fibrillation is largely unclear. Colchicine can prevent the occurrence. And that sentence, I copied and pasted it, and it's a bit difficult to understand, but I think essentially you just can't, nobody knows how long to give it for, and they're saying future studies are needed to look at optimal duration, dosage, and that. And it's just a sort of, hopefully, a talking point where I think my senior partner can actually give us some guidance on this. So whether we think, in my practice, should we actually consider this? Because I certainly haven't been doing it since this point, and I don't know enough in terms of the evidence and that. So, James, I don't know if you want to...
Well, I think with the use of colchicine, it's sort of come and gone. And it comes back again. And I think, in fact, I think Martin was using it at Moore Park. But I think it's important to who's at risk for atrial fibrillation is the most important, because we don't tend to see it in the young patients that go for surgery. So we know the incidence increases when you reach 80. About 50% of patients will do a post-operative AF, whereas the 40-year-olds, the incidence is about 3 or 4%. So I think if you're going to use it, you've got to, I think, because it's relatively innocuous. And most of the AF occurs on day 2 or 3, if it's going to occur. And then very rarely will you get a patient getting AF post-operatively after they're discharged from hospital. So I think if you're going to use it, then one should probably use it for that first 6 weeks, I would suppose. But I think it's AF is multifactorial. And if you do off-pump surgery, you reduce the incidence by 50 to 60%. You halve it. If you posterior pericardiotomy has been shown to reduce it by 2/3, which is another thing. If you do sympathectomy, if you take all the sympathetic fibers off the aortic root, which we don't do, also reduces it. And I suppose if you add colchicine, maybe you can reduce it some more. I think the only thing is the side effects are the issue. But I think using it's relatively innocuous. But I would advocate using it sort of for, that first 6 weeks. I wouldn't take it for 3 months.
No, definitely.
But I think I would also look at using it in the at-risk population, maybe the over 70s or people that are going for valvular surgery. But again, it's an age-related problem largely. And old people, drug side effects are more of an issue for them. Old people are either constipated or got diarrhea, so you've got to be careful with what you give them. But it's sort of been in and out of vogue. I think somebody did a study and then everybody used it, and then somebody else did a study and the results were insignificant, so they stopped using it. Meta-analyses are, by their very nature, not the best evidence. You still need you can do a randomized controlled trial with it. And the reason they've done a meta-analysis is probably because the evidence is conflicting.
Exactly.
And one thing I'd like you to explain to me, the dersimonium-led random effect. What is that?
The dersimonium-led random effect.
It says that the dersimonium-led random effects model. I don't know what that is.
Oh, with the methods.
It sounds sounds terrific.
No, it does. It's down. I have no. With the meta-analysis, Cochrane got a software analysis system, and I don't understand. I just know they basically plug this thing into the software analysis, and there's a statistical analysis, and these things come out. But actually don't know what
It's,
that is.
it's
Yeah.
not in ERAS.
Yeah, that's the thing, because ERAS is now, we're all moving towards ERAS. And I mean, this is relatively recent thing, December last year. So obviously as clinicians, we say, all right, does this fit in or does this not fit
I
in?
think
Or
we
does
can
it?
write to Dan Engelman and ask him,
Yeah, yeah,
because I'm sure they'll be looking at it as
yeah,
well.
yeah. Yeah, and it's really nice. It's a small little topic in there, but it stimulates thing about our practice. You know, we must think and we must change and stuff. And there's people that know. And the greatest thing about this academia is, you know, if you go on these, and for all the guys watching, like an amazing, if you don't have a subscription to journal articles, you know, I get articles for free. You just email the author and they send it to you for free, 9 times out of 10, because these guys are interested in the subject, not the money. So it's actually amazing. Like while I was doing my research and all of that, there's a bunch of stuff I wanted, and you just email the article because they give you the contact. And these are all doctors who have an email, and they like sit and look at it and be like, hey, somebody like wants to know this, I'll quickly email it. So just on that. So I think we must ask, and yeah, I think if anything else comes or anything changes, it'll be interesting to see. So that. Okay, so I think let's move on to the next talk. So, sorry, I don't have a name, but iPhone. Somebody with the iPhone's got their hand up. Is there a question or a comment?
Hi, sorry, man. It's Sanjay. Apologies. I'm not good with technology. I didn't put my name. I just dialed in. There's a couple points that I wanted to make. I read a very interesting article about AF, post-op AF, years ago when training as a registrar. And it was a good study done in the US. It was in one of the peer-reviewed journals then. And one of the things was that the volume of the right, excuse me, the right atrium, if it is not adequately filled, you end up with post-op AF. And they did a trial with that, and they found that loading the patient adequately with fluid and making sure the atrium is well filled, that the AF incidence reduces. And we were at Albert Luthuli when we used to have these post-op patients. We never used to give them cortisone. We used to just do this, and strangely enough, anecdotally, it was actually reducing it. When we read this, and we used to follow that protocol quite stringently as registrars. So we did that first before we gave drugs. So something to consider. And then the second thing is that colchicine, we use it freely from a general medical side for most things. And it actually works very well as an anti-inflammatory. So I think it has its place, and the side effects is really minuscule for patients. They tolerate it relatively well. We're not going in doses where we're using 0.5 milligrams QID and 6 hourly, etc., because that's when they really struggle with the diarrhea. But at lower doses, it does work. And then the last point I want to know that I just want your comment on this. You use cortisone prophylactically post-op in the patients. It actually is more toxic than colchicine or most other drugs. You had one fibrosis, but there's a lot of acute hepatitis. There's a lot of acute interstitial active lung disease that happens. And then thyroid is quite high incidence from all of them. So what's the rationale in that? And is there evidence that it actually prevents the AF post-op in using such a toxic drug upfront?
Okay, so yeah, it is a point of concern. I think there is evidence, recent sort of evidence that says one dose of amiodarone post-op is not related to more sort of major adverse outcomes. It's more the duration of the treatment. And if you look at the relative risk of adverse outcomes with AF,
I'll correct you there. It's actually not related to duration. It's the drug itself. So it's not actually duration.
Yeah,
so one dose is enough to create all those complications.
So that's like an interesting thing. I've sort of adopted that, and I think we did after the a discussion just like this, and I think it's good to have this sort of discussion to say, all right, is this actually the right thing, or should we do and certainly the one patient I had with lung fibrosis, he was on it for a longer time, but it was, and I think maybe I can ask the team and ask James to comment.
Answer the question. The randomized controlled trial published in the Annals of Thoracic Surgery last year was where I can give you the reference, where they actually showed a significant benefit in giving amiodarone in the patients that are at risk, as we do. And number two, the cortisone side effects, obviously there's two things: idiosyncratic, and then in general, the low dose does not seem to be associated with any clinically relevant pulmonary problems, unless patients have the idiosyncratic reaction. But most of the time, interstitial lung disease related to amiodarone is dose and duration related. And some patients, you stop the drug, it doesn't make any difference. In others, you stop the drug and they get better. But that's the clinical features of amiodarone toxicity. So in that trial was done in the United States, it was a large, proper randomized controlled trial, and there was a significant, I think they're more than half the dose, and half the duration of or incidence of atrial fibrillation in those patients.
Yeah. I also just want to make a comment, because I'm glad it came up that we have a right atrium that's full, that we have a proper preload. With our ERAS guidelines, our cardiac output monitoring takes care of that completely. We don't need a protocol and to, sort of just go on a gut feel of filling up patients. We work on the data we get from cardiac output monitoring, and we fill them up according to that, which is great.
That's part of the rationale
Takes the
of measuring
guesswork
a thing
out.
like a CVP, which I hope they did it at Albert and Tully.
Yeah, they do.
So, I mean, measuring how full the right atrium is very easy. That's kind of normal post-operative management of the patient.
So, Dr. Miraj, with the amiodarone and that, so the study came out in the Annals yesterday, and that, not yesterday, last year, and that's the sort of rationale that has been applied behind this. But as a group, we've always got to be discussing and seeing what's the best thing and the best way, and that's the beauty of this conversation. And Dr. Dralla, about the filling, 100%, he always tells me, like, you give a patient Lasix, increase the risk of AF because the right heart, and that certainly is a big thing. And it'll be interesting in our set of patients, to capture the data and actually look at it, because I think over the years we'll have a decent amount of patients, and if we capture the data properly, we can actually then, compare what's actually happening with our demographic of patient versus, the rest of it.
Just another point, when I was at the ATS, they were having the ERAS open forum, and Dan Engelman, who's the chief driver behind it from Boston, the one thing that he said, that there's no evidence for is the use of Lasix post-operatively in a patient without failure.
Good venture.
And so that's tended to be a thing that cardiac surgeons do. And he actually said there's no evidence for it. You've got to have a good clinical reason to give Lasix. So routine administration of diuretic in a patient that is a routine, doesn't need diuretic. And that ties into what Sanjay was saying about if you empty the atrium, gives the patient tachycardia, which increases sympathetic drive. Sympathetic drive is one of the triggers for atrial fibrillation, along with inflammation and the other. And beta blockers, use of beta blockers, pre and and early post-op. All patients should go to theatre beta block. That's something that can't emphasize enough. And that's why a lot of them need temporary pacing now. But the beta blocker and then pacing them afterwards reduces the likelihood of atrial fibrillation. Because you've suppressed the atrium, you pace them, and you get to about day 2 or 3, you stop the pacemaker, and then hopefully the drive to develop atrial fibrillation is also mitigated. So it's multifactorial, it's not a question of just one.
And once again, on the cardiac output monitoring, there's an algorithm that shows you when diuresis is actually valid. You don't have to guess any of this.
No, and certainly for me, because, as coming through training and coming through the system the way it is, and then eventually popping out as a junior in private practice, a lot of what we do is sort of just because that's the way we do it. You get taught and you just do it. If someone asks you why you do it, you'll be like, because my prof told me to do this, and I never questioned it ever. And it's amazing that now we can have these conversations and we can adapt our practices and evolve, and it's really, really, really valuable. I think,
That's why ERAS is so wonderful.
Yeah.
And that's a good opening for the next talk.
All right. So, is that fine? Any other questions on this? And then we'll move on to the next one. All right. Thanks so much, guys. Let me just try and get the next one.
Morning, everyone. Thanks for your time. So, about a month ago, Renee started speaking about ERAS and in the cardiac protocols, and it really resonated within Carmen and myself, and we were just thinking about how this would be working out in our context and how would we do it. And so we were doing a bit of reading, and our thought was just to chat a bit with Renee about how this could work, but this is where I've ended up this morning in front of you, so just be careful what you say. You might be seconded the next time. So enhanced recovery after surgery is what ERAS stands for. It's a multimodal and interdisciplinary optimization of the perioperative management of a patient with the aim of promoting early recovery after surgery, improving patient satisfaction, and reducing post-op morbidity and mortality, and trying to reduce the length of stay in hospital. The slide just shows all the components making up ERAS. It's divided into 3 phases: the preoperative, intraoperative, and post-operative components. In terms of physio, we are involved in pre-op, prehabilitation, and post-op early mobilization. So that's what we'll be talking about today. So prehabilitation. What is it? How early can we start? Is it for every patient? I don't have a nice, concise meta-analysis to go to because there's not so much out there to say exactly what we should be doing. So we're just bringing some of what we've read, but the discussion needs to continue afterwards. What is prehabilitation? For me, it's that time when I'm pushing and pulling and begging and pleading with a patient to get out of bed, and in my mind I'm thinking, I wish I'd had time with this patient before. That is what my mind goes to when I hear prehabilitation. It's quite a nice picture. The dotted line shows those without any intervention in terms of physio, and the solid line shows how we can boost a patient and get them out of hospital at a much, much higher level. So prehabilitation, the process of enhancing an individual's functional capacity to enable them to withstand a forthcoming stressful event. The aim is to increase respiratory capacity, muscle strength, and exercise tolerance to reduce the expected functional decrease observed in patients undergoing cardiac surgery. So it's an expected decrease. We know it's going to happen. So if we can boost them to a higher level before, how much better will it be afterwards? It is said that the pre-op course of prehabilitation must be based on cardiorespiratory and muscular training. For me, I was thinking more the cardiorespiratory side, but as we were reading, we seeing how much we actually need to get them stronger physically. And this article I came across, the effect of pre-op respiratory physio and motor exercise in patients undergoing elective cardiac surgery was I really liked this one. They divided their patients into 3 groups. Group A and B received pre-op physio, and Group C received nothing pre-op, only a post-op standard protocol. In Group A, they only did respiratory intervention, and in Group B, they did respiratory and motor physio. This was translated from Polish or something, so they're using the word motor. So let's have a look. So you can see Group C, how far down and far away they are from Groups A and B. In fact, so here they showed statistically significant improvement in peak expiratory flow. They did a measure the day before surgery and then the day of discharge. So those are the 2 points. And you can see how Group C, where Group A and B land up post-op is even far above where Group C started. And this one as well, the 6-minute walk tests, so it tests endurance. Again, look where Group C is sitting and where Group A and B are high above. In particular, Group B that included the physical prehabilitation. Again, you can see where Group C started and where Group A and B were post-op. It speaks for itself. Other things, they found a better post-op blood gas measurement with the prehabilitated group. Incidence of pulmonary complications. If we look at Group C first, it was 10%. Group A was 5.3%, and in Group B it was absent, which I thought was quite a story. Length of hospital stay was also reduced. Group B was 7.4 days average, A was 9.7 days, and C was 12.6 days. So we can get them out of hospital earlier. The question is how long? How long before? It's obviously limited by the urgency of the surgery, but in terms of what we've read, some say 5 days of respiratory physio before has an effect, and others say 5 days does nothing. Others use 2 to 3 weeks beforehand. Others used 8 weeks. So it's very, very varied. We'll have to just, again, chat about how it would work here. Who would be involved? Obviously, elective surgeries would be able to enroll in the program versus the emergency. Patients motivated to participate. Patients able to come in on an outpatient basis, those cognitively able to follow the instructions, those physically able, sometimes there's an orthopedic factor involved as well. Those deemed safe to participate following the doctor's evaluation, so we'll get them after the doctors have seen them. There's a number of assessment tools that we could do beforehand. Obviously find out what their physical activity normally is. We can do some frailty scale, 6-minute walk test, 5-minute gait speed test. There's a whole lot that we can use just to find out where they are, what is their baseline. But basically, we want to encourage them not to wait until it's all fixed. Sometimes when people get told they need to go for surgery, they just stop and go, well, once I'm finished with my surgery, everything will be fine, and they just expect things to get better. There's a lot of hard work, but we can build them up from whatever, even if they're doing bed exercises and breathing, we can still prepare them. Good. So the next in phase 3, in terms of physio, early mobilization is key. I've been asked specifically to emphasize this. Mobilization for us can include turning in the bed, it can include bed exercises, but in that ERAS components we had earlier, they actually used the word early ambulation as opposed to mobilization. So we're talking more about getting out the bed. It speeds up, the benefits are well documented and almost indisputable about early mobilization being imperative. Just running through some benefits, it speeds up the patient's recovery, reduces ICU and hospital stay, reduces morbidity and mortality, improves functional status, enhances the patient's mood, improves BP, heart rate, oxygenation and ability to expand the lungs. The list goes on. We can talk more if you'd like. Just to say that it's been proven that early mobilization is safe and it's feasible, it's cheap, it's an effective intervention, and it's to prevent and mitigate complications. There are barriers. We could have POF, we could have vomiting, diarrhea, we can have an unstable patient, or the patient might be too drowsy, all of those things. But the barrier should not be our willingness. So here we're talking more nurses and physios. There's many excuses. The lines are too short, the cardiac output monitor is just in the way, there's too many things attached to this patient, we can't do it. But as the nurses are the gatekeepers and the actioners, and you guys are in charge. So if you are ready, then everything else can happen. Be ready to move, not ready to dissuade the physio about working up how I can. So have your meds in, your pain meds. Tell the visitor that it's soon for the physio to come. So everything's ready, everything's going well. Make your lines longer, please. But the team we've been working with recently has been amazing, and it's been good. The readiness is there, and it's been really, really good. So just a list of many complications of bed rest: lung infections, atelectasis, pleural effusions, impaired oxygen transport, delirium, DVT, hospital-acquired infections, pressure sores, decrease the functional capacity, interrupts activities of daily living, lots of things. Increases rate of hospital readmissions, and that we've seen as well. So coming to a landing, if we can imagine if we could boost these patients before, so we add the prehabilitation plus the early mobilization. We can't do the one and then fail on the other. We can see people achieving all those ERAS aims. So in conclusion, what are we doing? How does it add to what we're doing already? Prehabilitation gives us a stronger, readier, and more compliant patient. Early mobilization, Dr. Fulton's spoken about day one, post-op out of bed after bypass. We need to filter that through if that's what you want to do. It needs to be written down, because if it's not written down, then it requires a multidisciplinary readiness, early extubation and opioid sparing, like you spoke about last time. Imagine if 6 hours post-op we could extubate, have a patient that's awake and ready. Nursing staff ready and motivated means our patients can mobilize early. So just imagine if we could get it all going well. It's looking good in my mind anyway. So thank you very much for including us in your patient treatments and your and we can learning and grow with you. So thanks so much for your time.
That was an excellent presentation. I feel motivated right now.
But I think everything that you are saying, people are sort of wondering why I've been in my bonnet about getting the patients extubated. And you've seen it so often. If the patients are not extubatable, that's great. You should know. But if the patient can be extubated the same day of the surgery, the next morning they're awake and they're not drugged, and then they can have physio, and it's like a domino effect in a good way, because the earlier the patient mobilizes, the sooner they get out of ICU, the sooner they can be climbing the stairs, and the sooner they go home. So it translates to a whole lot of things. Patient well-being is improved. But you've seen it so often. If the patient is still sedated at 8 o'clock in the morning, they take 3 or 4 or 5 hours, and 2 o'clock in the afternoon they're still on the ventilator because they're not awake. And then they say, well, we don't want to extubate them now because it's afternoon. The evidence is very clear. And the anaesthetists are smart guys. They can see who is going to be a problem and who isn't. So the ones that can be extubated, we should extubate them. And obviously they've got to be stable and not bleeding. That's kind of not rocket science. And then they can get their physio. And then they don't need the cardiac output monitor the next day.
Yeah.
Cardiac output monitors for use perioperatively when the patient still needs iron drugs. When they're awake, the patient's blood pressure usually comes up. You can get them off the iron drugs. You can mobilize them. You don't have the lines problem. You can get them to cough. And again, that sense of well-being that patients get. They look different. When you've extubated someone the next day, they can be out of bed. There is a bit of inertia in trying to get people to do that. But the patient should be out of bed the next day, provided they're hemodynamically stable. It's good for them to sit in the chair. They feel better. Their family thinks they look better. And their recovery accelerates. Whereas an extra day on a ventilator, we know all the risks that go with that. The pulmonary emboli, the chest infections, the atelectasis, the hypoxemia, all things. The gut doesn't work. So it's all part of that. But you guys can't do it if the patient's not ready.
True.
So the onus is on the nursing staff to buy into this idea, because there is a bit of inertia. People say, no, we don't do that here. I didn't know these rules existed in Pietermaritzburg.
Yeah.
But it's not to make your life miserable. It's to make the patient better. And it does require a lot of nursing care, a lot of nursing people to get the patients out of bed. So it's the idea of what we're trying to do is enhance recovery. They used to recover before, but we want to enhance their recovery.
I'm going to say it's almost like you have to be a bit braver, because having a patient that's just gone for open heart surgery get out of bed day 1 post-op feels huge. Day 2 is soon as well, but day 1 is like...
I'll say I come from 2 centers previously to here where we used to do day 1 mobilization. In fact, we did it before the physio came. The nurse was expected to do it, the night shift nurse. So on handover, the patient is in the chair already. And the physio will then find the patient in the chair and walk with the patient.
Sure.
So for me, I actually, when I was then exposed to this area, I actually felt terrified, because I felt like my patient was going to get an infection, was going to get VAP, was going to get pneumonia. Yeah, because the patient's just lying there. And I actually had the opposite. I felt scared because no one wanted to mobilize the patient. Yes. It becomes ingrained in your care once you start doing it every
That's how I feel
time.
about a patient that's not out of bed on day 2.
There's an interesting article in this month. I actually came across it while I was reading this, and I was speaking to James yesterday about it. They did a study and they said just 2 days of pre-operative consensus spirometry,
Yeah.
just 2 days,
I wanted to ask that.
had earlier extubations, better blood gas, less mobility, and less mental. And then James said he's going to send everybody home with a balloon to come for admission.
I really like the PEEP exercise, because a lot of them smokers, then atelectasis, and you've seen them using spirometry. They really not really exert themselves, and they were playing. So but if they can blow out a balloon, you'll realize that they're ready. And the other things I was saying is that I think a lot of centers with elective surgery. So in our settings, people get a cath, and then if they got main stent stenosis, very soon they refer for surgery. Sometimes they don't go through this process. I think James or mentioned in America, they say you have to quit smoking before I do the cardiac surgery on you. But sometimes in our setting it's fairly different. But I think from our aspect, we understand ERAS. So as soon as we have a bypass, we refer. So we say, you know what, start working on them, start preparing, even with dietitian as well. Get them primed and ready. They're commonly either a chronic smoker, diabetes, hypercholesterolemia, or that combination. But I think working towards this has been great. I think with the new changes also been great. I think the early mobilization or ambulation, it depends on how the surgery went and what patients' pre-mob conditions and all that.
Yeah.
But I'm glad that I think it's working well.
Yeah.
I also think that spirometry thing you mentioned now, maybe we could do a bit of homework now after this to see how we should do that. Obviously, if they get taught it before they opt, they'll probably be better. But that's also, I feel like, a big thing for nurses to buy into. If you get the nurses on board with spirometry, most of the spirometry is actually supervised by the nursing staff.
Yeah.
You guys will only see the patient once or twice, but the nurse could do it every hour if you get their buy-in, and then you have a huge difference in the spirometry.
Yeah.
So maybe we could look at that, and then a prehabilitation protocol, and then obviously our mobilization. We'll figure out like a pathway to follow.
I think like with all of these protocols are great because everybody knows what you're trying to achieve. But always just remember to pick your fights. Don't be silly. We can identify who's supposed to be out of bed on day one, and who isn't. The idea is not to be sort of silly and say we're going to just pull the tube on everybody, and then you re-intubating patients at 2 a.m, which is kind of the nightmare. And I think that's where a lot of the resistance to extubating patients has come from, is people don't want to be called at 2 a.m. to re-intubate people. But we know who we can extubate, and we know who can't. And the one thing that I don't like is extubating people onto NIV and CPAP, because that just keeps them in bed. I think the idea is that it's better to rather use something like high flow, and spirometry is better for those patients. So, we've got to pick our fights. I think we've just got to be sensible about what we do. We should be able to extubate 80% of the patients. Bruce?
Yeah.
But
Not
maybe
everyone.
we could design our ERAS to be like, okay, this is plan A, like this is what we ideally want to do, like we could have the respiratory and motor prehabilitation exercises. Plan B is just respiratory. So then you guys would assess the patient, say, okay, for this one we're doing A or B. Or we can say extubation, A would be 6 hours, B is we'll reassess.
I think it might also help the patients psychologically if they've got these elective sort of patients to see physio beforehand. I think it's because they go home and then they sit at home and waiting for this operation day, and they probably, as you say, they don't want to do anything because
They're scared. Yeah.
So maybe that'll be another additional.
Some of
And that's if you're
the
nice to the patient.
some of the people were actually given like homework, like a sheet to fill in every day what they've done. So it's almost like a motivational thing. And then when they come in or straight after, there's a sort of culture that they've started of moving and trying to achieve a certain thing.
It's very cool. We can design this really nicely.
I've got that, like my thing is patients want to know how they went when they go home. I said you can climb 2 flights of stairs. That's about the level of my physiotherapy. But most of the patients who go home on day 5, day 6, day 7, they can climb 2 flights of stairs.
That's the motivation.
That's
Just a comment. I just think, coming from where I'm coming from, Mill Park, the pre-op preparation for the patient, to give that patient those exercises to do pre-op. And then also you're planting a seed of motivation in the patient that, okay, I'm going to see you on day 1 and we're going to start physio. patient has something to look forward to and actually helps with the healing as well.
We do at the moment. We pre-op, day pre-op, when everyone else is trying to see the patient as well. We line up outside the ward. It really does help. So we do get that. It's even like forming a relationship and motivating them. Yeah, it works well. Letting them know what the incentive spirometer is supposed to do, because afterwards they're lifting the ball so far and blowing up the balloon. So it works very well, what we've been doing, but I just imagine what it could be like.
So on ERAS cardiac guidelines, they say we should do this as I don't know if you saw it, this new approach. So it's nutrition, exercise, and worry rehabilitation. So in my mind, it would be so great. Now I'm thinking of our patients now, not is to have like a ERAS clinic. So pre-op, once they've been referred now for the bypass and spoken to the doctor and everything, and they come to this clinic, they see the dietitian, the physio, and then the ERAS coordinator. We need to start the program. They'll have like a passport, journal, something. We'll figure it out and start, like you said, like give them exercises. They can complete that, and then that would be a great way, I think, to approach it. Something like that. Yeah.
So imagine if you have all of this. You wake up now after you've been extubated, and the nurse doesn't want to be part of that program. They're negative. They say no, it's too dangerous for you to get up. That just deflates the whole thing. So nurses really do need to be on board.
Cool. We have one more. Does anyone else have a question for the physios on their side of ERAS?
So we have one more talk. I think we can go straight into it when James can.
Okay. Yeah, saying this is not really a talk per se. It's just apropos, some ECMO referrals and when we get the patient, and the ECMO is what it is, and we hear a lot of things repeated frequently, like I don't believe in ECMO. It's not a church. Okay, ECMO works and it's very effective. However, patient selection is everything, and what needs to be understood, hopefully by the general medical population, from the emergency department, the nursing staff. I mean, who should get ECMO, and who should be referred for ECMO? We've sort of run through ECMO in the past. There's VA ECMO for circulatory failure and VV ECMO for respiratory failure, and VA can be used for failure of both. And the idea is to get the patients referred early. Now, the Alfred Hospital in Melbourne, which I'm sure you're tired of hearing about, it's the second largest lung transplant center in the world. It's set the standard really for ECMO centers, and also they release all their information is available, so they share all their information, and you can get it online on your phone 24 hours a day. So there's no guesswork involved. Again, what we're trying to do is remove the clever people from the equations and rather say what is the best available information. And I think that's the best available information. There are a lot of places with protocols, but the Alfred, obviously I'm a little bit biased because I did spend some time there. And it's simply getting the patients for circulatory failure referred early. I would say I've been asked to see about 5 patients in the last 12 months. Most of these patients have been referred 24 hours too late. And what is too late? They've been on massive doses of inotropes with circulatory failure, and then the patients are getting worse, and then somebody says, oh, maybe we should think about ECMO. When you see the patient, their pH is 6.8, their kidneys have shut down, and they're in multiple organ failure. Now, that is FECMO, futile ECMO, and there's no point in ECMO. So the patients, ideally in the Alfred, they've got the shock protocol that a patient that you anticipate hemodynamic instability, they should actually be part of the team that treats the patient. So if the patient presents to casualty with chest pain and a tachycardia, and he's peripherally vasoconstricted, that's by definition shock. Although he's not yet hypotensive, hasn't collapsed. Because what they would do in a place like the Alfred, they'd say, well, this guy is going to get into trouble. You need to revascularize him urgently, whether it's percutaneously or surgically. They put those patients on ECMO, and they have a very calm revasc procedure that can take 3 hours if they want to open all the vessels. And the patient then goes back to the critical care unit, and the ECMO is weaned off and removed based on the guidelines, you know, as you see with transesophageal echo. So the idea is to get the patients referred before they collapse, ideally. Obviously, that's not possible in all patients, but so when there's impending hemodynamic instability, and I've seen patients like that, and you follow their journey, they've been in the hospital for 36 hours, and they go and have an intervention, and then they fibrillate, and that's when, you know, you're called, and so you're playing catch up. So you don't want to put someone on ECMO that doesn't need it, but you want people to think about ECMO, because inotropes are great in low dosage. The Alfred cutoff is 0.2 mics per kilo per minute of adrenaline only, no constrictor. Once you reach that level, the ECMO team needs to be involved and see the patient. You need to get all the data together and say yes or no, but rather than. And if you don't do it, then you keep a very close eye on the patient. And if they improve, then you don't put them on ECMO. But the problem is, you know, you should not ECMO dead people or dying people. It might sound trite, but patients on unmeasurable doses of vasoconstrictor and unmeasurable doses, you know, I've got a bee in my bonnet about the 70 mils of something, but no one can tell me how much it is. And when you work it out, it's 0.7, which the noradrenaline should be capped at 0.4, and so should adrenaline. That's maximum effective dose. After that, all you're doing is killing the patient. So, you know, when you get to those levels of inotropes, the patient should long ago have had an assessment for ECMO. And it should ideally be the patient less than 65 without multiple comorbidities. You know, we're not trying to save patients with multiple organ failure and disaster. We're wanting to save, well, people like me, you know, or any of us around the table who has the misfortune of having some catastrophic event. The other one is blunt chest trauma, where they can't ventilate the patient. You know, injurious ventilation, and Bruce is going to talk about injurious ventilation next week. When should you consider VV ECMO? Not after 5 days of injurious ventilation, because you've injured the lungs to the point that recovery is unlikely. Those patients also should be ECMO'd early. The COVID ECMOs that we had all did badly, and there was a simple reason for that. Most of them refused intubation. When they were intubated, it was when they decompensated and they were septic. So they had septic shock on top of COVID. Septic shock is a relative contraindication to ECMO, except in a young person with no comorbidities. So, you know, just to get that right, if you want ECMO to be effective, it's still got to be early referrals. And Bruce is going to talk more about ventilation next week, because I think that's also important, that, you know, how do you look after the lungs, and when should you ECMO them? And that'll come out in that discussion. But people need to understand that ECMO works well, but not too late. I mean, we had that patient at St. Anne's, and the patient was also referred very late. Patient pH was 6.88 when I saw her for the first time. Her kidneys had shut down, and she was on unmeasurable doses of inotrope. Anyway, and yeah. Anyway, so the idea is just to get we put her on ECMO because she was 34 and she had 2 small children. You know, that's maybe not a good reason, but she actually did well, and we got her off the ECMO. And she was in circulatory and cardiac failure. And so we could have salvaged her, but she was immune compromised, and she developed late sepsis, but 2 weeks after the ECMO had been taken out. So we'd like to call that a successful ECMO. But, you know, ECMO does work. But before the kidney shut down, I think is and that's all I'm going to say about it.
Ken, I think, you know, it's so important that as we develop and grow and become a better and better place, the culture around thinking about ECMO, we've got to try. Doctors and nurses and that. It's not this thing that's hidden away in somebody's back, you know. We've got to start thinking about it, and I think we've got to develop a culture of asking early. And we shouldn't ever be scared of anyone, you know. It doesn't matter who you are, junior person or senior person. If you say, should we consider ECMO for this patient? The team's obliged to actually answer that. But if nobody asks the question, then it's not being considered. So that's the one thing I just wanted to say. So early referrals, we got to drive it. And the other thing is, we got to change the way we do inotropes. I think actually knowing per kilogram per minute how much we're giving a patient makes a huge difference. Suddenly the way I sort of am used to it is once you get to 0.15 mics of adrenaline, then you're just going to get more alpha and alpha and alpha, so you must think about whether you need a vasoconstrictor. And then if that's not working stuff, you need to think about support. That's actually not, in terms of molds, it's very difficult to know what it is. Also, you don't know how many ampules and how many is a single strength and double strength and all of that. And it makes a huge difference. But we got to see these patients as any one of us here could be that patient, and that decision needs to be made. And I would love to see the future where all the infusion pumps change. And I know it's difficult because lots of places around the country, everywhere, lots of places use molds, but you can actually have molds and the mics next to each other on these pumps. And maybe we should start. And that's all.
It's not a maybe. It's not a maybe. It's a for sure.
Yeah. I think on this journey of ECMO, we started with the meeting, but I think the important thing for me now is that as we start going out to a different territory, I think we need to have a central point of referral. So the information does not get misled or mispresented, and therefore the wrong decision subsequently being made. And with our experience with patients in St. Augustine, where there is a group and everybody contributed, and we can learn so much more from decision making and as well as patient selection. Now, if we select well, they will do well. But the question is that selection process is only coming with time. And remember, before we setting up the meeting, I always thought in a group there was 2 surgeons. I think Cape Town model was 2 surgeons and 1 pulmonologist. So when they have an ECMO referral, the information and data will be fed into a system, like a WhatsApp system or Telegram or whatever it is. And the surgeons who are involved or the group, a decision will be made because the information they presented will be holistic. We'll say, oh, what about this, what about that? And all the information once being presented, the guys will say, okay, I agree this patient for ECMO. And 2 surgeons and 1 pulmonary or physician or who needs the group. And then once there's 3 go ahead, then the team must be ready to be mobilized to say, okay, either we're going to install the ECMO, set up the team, and then go ahead from there. I think that help with the smooth transition. That's what I think.
I think a logical, rational decision-making pathway. It's not rocket science. It just has to be logical and rational, but it requires awareness and buy-in from everyone. We can save a lot of people's lives, and I think that's what we're all doing.
Yeah, and I think also the point of this little discussion is not to deter you from referring. for assessment, but it's just so that it happens perhaps earlier. You can refer the wrong patient for ECMO completely, but that's why there's a team that assesses the patient. You can use the Alfred guidelines as your reference, but the point is earlier.
Because all the cardiogenic shock patients die.
Yeah.
And it's not the ceiling. The ceiling is not 70 mils of inotropes. There's many more steps that could have been initiated if it was in time.
All right, guys, I think we're going to call it a great session. Thank you very much.
Does Mark have something to say?
Sorry, Mark.
Mark, have you got something to say?
Hello.
You have to unmute yourself.
You're mute.
Oh, Mark, you're on mute. You're on mute. You're on mute.
Can you hear me?
Yeah, thank you.
No, just to give the sad news that the patient in Hillcrest that we put on ECMO, the guy who lost his leg, unfortunately, he has now presented with invasive carcinoma of the head of the pancreas. So he's not doing too well. How's that for bad luck?
Yeah. Yeah. No, that's terrible.
Yeah.
You kept him alive for a bad reason.
Thanks, Mark.
Thanks,
Okay,
Mark.
guys.
Thank you.